Good afternoon, everybody, and welcome to the first of our clinical translational research seminars for this academic year. As in the past, we have a group of really fantastic, distinguished clinical translational scientists speaking, as well as interspersed with some of our awardees of our pilot projects and mentored research awards. So it's going to be a great season. And check out the Advance-CTR website for a full list of the speakers. So today it's really a great pleasure to introduce Dr. Gaurav Choudhary, a friend and colleague for quite a few years now.
20 now, Sharon.
Yeah, who's counting? Gaurav is the Ruth and Paul Levinger Professor of Cardiology at the Warren Alpert Medical School. He's Associate Chief of Staff for Research at the VA Providence Health System. He's also the Director of the Brown Cardiovascular Research Institute, located at Lifespan. And he has really been a wonderful force for enhancing cardiovascular research in our community. Gaurav came to us by way of the All India Institute for his medical school training, which is the most prestigious medical school in India. He then went to Michael Reese Hospital in Chicago for internal medicine training and to Emory University for cardiovascular fellowship. He's been located at the VA in Brown now for a few years and has built a really terrific research program in cardiovascular disease with an emphasis on pulmonary hypertension and right ventricular failure. In addition to everything else he does, he's also the PI for the cardiopulmonary vascular biology COBRI, and he is lead of the pilot projects program for Advance-CTR. So we owe him a great deal of gratitude for his great work with Advance-CTR. So today Gaurav is going to be talking about pulmonary hypertension, definition, epidemiology, and novel therapeutic targets. We would ask that attendees enter their questions into the chat, and we'll address them at the end of the talk. And take it away, Gaurav. And thank you.
Oh, thank you. Thank you, Sharon, and the Advance-CTR team for giving me the opportunity to share some of my work. And also, it's been a pleasure working with the administrative core and our pilot project core and helping so many investigators across Rhode Island. And Sharon asked me to talk a little bit about how I got into research and what, how I got interested in it. So, I did not do much research in medical school. First time I got interested in research was in residency, and it was because of great mentors there that I found. It was completely unrelated to what I've been working the rest of my life, but what I learned working with them and seeing the excitement that they had is how the process of discovery can be so rewarding. While challenging at times, I think at the end, we have an opportunity to make impact in people's lives. So with that said, I think I would try to go over review some of the work we've been doing. This is not meant to be a comprehensive review of pulmonary hypertension, but probably more focused on some of the contributions that we have made and some of the discoveries that we have made in Rhode Island at the vascular research labs in Providence. Before we start with pulmonary hypertension, and I wanted to kind of introduce because we have a diverse audience on pulmonary circulation. So we all know that the right ventricle is the part of the heart that pumps blood through the pulmonary artery to the lungs, where it gets oxygenated, and that oxygenated blood goes to pulmonary veins, and then to the left side of the heart or left ventricle, which pumps it to the rest of the body. So the alveoli in the lungs are the ones that oxygenate it, and this is the dense capillary network that helps oxygenate the blood. So the pulmonary circulation is a low pressure, high compliance circulation. Well, what does that mean? Well, pulmonary systolic pressure is around 18 to 25 millimeters of mercury. We all know that our systemic blood pressure is about 120 millimeters of mercury. So very low pressures in the pulmonary circulation. It's usually maximally vasodilated at baseline. And the resistance across the pulmonary vasculature is usually low, and if it changes because of vascular tone, so vasoconstriction. That could be in response to mediators or oxygen. Oxygen is one of the most potent vasodilators. Lack of oxygen causes vasoconstriction. And then recruitment of capillaries is another way that you can change the resistance. So if you lose capillaries, the resistance could go up. If you increase the number of capillaries that are recruited, resistance could go down. And the compliance is because this particular circulation also accommodates the whole cardiac output that the rest of the body accommodates. And when we're exercising, that could be 10, 15 liters per minute. So without significant change in the pressures in the pulmonary circulation. So there's an ability to accommodate a lot more blood in this circulation without changing the pressure, like the systemic circulation. So what is pulmonary hypertension then? Well, pulmonary hypertension is high blood pressure in the pulmonary circulation, and the way pulmonary hypertension is defined is use of mean pressures in the pulmonary artery, and we'll go over some of that in a little bit. So what would cause elevated pressures in the pulmonary circulation? Well, it can be divided into two big parts. One is post-capillary, so everything happening after the alveoli in the post-capillaries. And so, for example, one of the most common kind of pulmonary hypertension is when you have problems in the left ventricle. It could be a valvular disease. It could be left ventricular systolic or diastolic dysfunction, which basically increases the back pressure. So it increases the pressure in the left atria, and those increase the pressure in pulmonary veins, and then pulmonary capillary wedge pressure, which is a way you can measure the pulmonary venous pressure by right heart catheterization. And that would obviously increase pressures on the pulmonary arterial side, causing pulmonary hypertension. Other group is pre-capillary pulmonary hypertension, where what's happening, the pathological changes are happening in the pre-capillary areas. And that could be, and this is a normal looking pulmonary artery, you see a single layer of endothelial cells, maybe a few smooth muscle cell layers. This can get remodeled. And if it's remodeling, that there is increase in smooth muscles or endothelial because of a number of conditions, could be idiopathic, could be heritable, could be related to certain kind of diseases, that obviously would increase the pressure. You can have vasoconstriction. So if you constrict this artery, the pressure would go up. You can have an occlusion there, and that would increase the pressure. Or you can lose some of the capillary networks, and so your cross-sectional areas decrease, and that would increase the thing. And all these things are happening on the pre-capillary side. And these are the things that helps define the classes of pulmonary hypertension or groups of pulmonary hypertension we talk about, such as pulmonary arterial hypertension, where there is intense vascular remodeling because of a number of reasons. Pulmonary hypertension due to left heart disease, while mostly passive in nature, sometimes is also associated with active remodeling in the pulmonary arteries. The lung disease and hypoxia result in vasoconstriction or capillary loss more commonly, and some remodeling that would lead to pulmonary hypertension, or clots like chronic thromboembolic pulmonary hypertension that will lead to increased pressures. So now we know that how the pulmonary hypertension is classified in these 5 groups: pulmonary arterial hypertension, left heart disease, lung disease, thromboembolic, or sometimes it can be multifactorial. How do you classify it? So we technically use hemodynamics to classify these pulmonary in these groups. So the first one is mean pulmonary artery pressure, which if you have pulmonary hypertension should be increased in all of them. And you have the wedge pressure, and this is the left-sided pressure. And as you can imagine, it's only increased in the ones with left heart disease, but normal in all others. Increase in pulmonary vascular resistance, which is increased in most of them. There is a possibility that it can be normal when it's the left side disease because of the passive backup of the pressure from the left side only. And so most of them are pre-capillary in nature. The group 2 of the left heart disease could be pre or combined pre and post capillary, or post or combined pre and post capillary. So as you can see, hemodynamics play a really important role in diagnosis and classification of pulmonary hypertension. However, historically, there's been a little data that was available to justify appropriate thresholds. And a lot of that was based on consensus. The thresholds were based on consensus statements, and then not really a lot of robust, large-scale data that was available. So that gave us an opportunity to look at large databases with hemodynamics, and these are all invasive hemodynamics because you cannot get it non-invasively that we could find. And one of those areas was the VA. So VA has a national program where all the right heart catheterization and left heart catheterization data is collated at one place, where then it can be linked to the patient's phenotypes, and then you can look at a number of things, even including longitudinal follow-up and outcomes such as mortality or hospitalization. So we started with looking at mean PAP. We were able to get 21,000 individual cases at 75 VAs across the country. And we started looking at, well, with each millimeter increment of mean pulmonary artery pressure, how does it affect mortality? And the traditional threshold of pulmonary hypertension at that time was 25 millimeter of mercury. That's why you see these two colors. But what we noticed that actually the pressure, the mortality starts increasing as early as 19 or 20 millimeters of mercury, and then it keeps going up. We also looked at pulmonary vascular resistance, as that was another important hemodynamic marker to define pH phenotype, which the threshold was 3 millimeters of mercury for many, many years, 3 Woods unit for many, many years. And when we again started looking at a linear increase in PVR associations with mortality, you can clearly see that the mortality risk starts increasing very early, almost at 2 to 2.2 instead of 3 millimeters of mercury. And this shows a little bit higher because this is only restricted to people with higher mean PA pressure. Again, 40,000 cases showing that for PVR 2.2, the hazards of mortality already is 47% higher than control. And the third important parameter is wedge pressure. And again, looking at the wedge pressure across the cohort is 32,000 patients across the VA, we can clearly see a U-shaped association, which is not surprising, where an optimal wedge is around 12 millimeters of mercury, but certainly starting around 15 or so, you start seeing increase in mortality. So this helps justify the thresholds, and some of them were changed with the help of some of the data that I showed you in the prior slide, where the mean PA pressure greater than 20, wedge pressure of greater than 15, and PVR of greater than 2 Woods was chosen as the thresholds for classification of pulmonary hypertension. But if you want to look at prevalence of pulmonary hypertension, which is the next thing I'm going to discuss, it's really difficult to use right heart catheterization as a measure to estimate prevalence because it's an invasive procedure, and we won't be going around doing right heart catheterization in people to estimate prevalence. But another common tool that's used is echocardiography to screen for pulmonary hypertension. It's non-invasive, it's inexpensive, readily available. It can measure the PA systolic pressure, not the mean pressure. Mean can only be acquired through right heart catheterization. And it estimates RA pressures based on IVC size and collapsibility. So, this is just an echocardiogram showing the right ventricle on this side and right atria on this side. There's some leakiness across the tricuspid valve, which this continuous wave Doppler is measuring to estimate the flow profile across there. And using this flow profile and modified Bernoulli equation, we can estimate a gradient across the right ventricle and right atria, add the right atrial pressure to it to get PA systolic pressure. And then the accuracy, obviously, for this non-invasive parameter is limited compared to right heart catheterization, but the sensitivity and specificity of this parameter to diagnose PH may be reasonable. And again, to just show you here the correlation between systolic mean pressure and mean PA pressure, and this is all cath data, the systolic and mean PA pressure really correlate well. And a systolic of about 40 correlates with mean PA pressure of 25, which was the prior definition of pulmonary hypertension, and about mean PA pressure of 20, which is the new definition, relates to about PA systolic of 30 millimeters of mercury. All right, so now we have this tool, and we've had this tool for estimating the prevalence of pulmonary hypertension in the community. What do we know about it? So the first set of studies I'm going to highlight are related to community-based population. So again, random sampling of residents who are living in the community who undergo echocardiograms and then see how prevalent elevated PA systolic pressure or pulmonary hypertension is. So the first one was done at Mayo Clinic, Olmsted County, where they looked at residents greater than 45-year-old, about 43% male, pretty much all white population. We looked at the estimate of pulmonary hypertension. And about, if you take the threshold of 30 millimeters of mercury, which is equivalent to about 20 millimeters of mercury mean pressure, about 1 in 4 would meet the criteria of elevated PA pressure. If you take the older, more restrictive criteria, about 2 to 3%. This is again a study done in Rotterdam. In the Rotterdam study, again, random participants, a little bit older, with more than half women. Similar kind of prevalence numbers. 1 in 4 greater than 30, and about 2.6% greater than 40. Most of these populations were Caucasian populations, so we had access to Jackson Heart Study. Brown has had a long-standing relationship with them, and using that cohort, which is an African American cohort, the random sampling of African Americans living in Jackson metropolitan area, about 3,200 subjects here, predominantly women, and a little bit younger population, but a lot of comorbidities. We saw the prevalence of pulmonary hypertension or elevated PA systolic pressure was much higher, almost 35%. And if you look at even the conservative criteria of 40 millimeters of mercury, about 5.6%. So a lot higher. And we delved deeper into what may be the mechanisms of higher pulmonary pressures, and we can talk about it a little bit later during one of the comorbidity slides. But we don't have a mixed racial population to look at the effect of race on this, but we believe that this is more related to changes in comorbidities that you see in these populations. All right, so that's the people who are random. There are very few studies which look at random populations, but I think they're really helpful in seeing what's out there, because obviously you would expect a higher percentage of patients with any disease in a referral population who are coming to get an echocardiogram done or a right heart catheterization done. But then we have a lot more data available from that. So we started looking at some of this data, and there was not a big database around that time, and we looked at the VA data and combined the data from Providence and Boston. And some of this VA work was done with a very close friend and colleague, Brad Maron, where we've collaborated on these projects. He was at VA Boston at University of Maryland. And so we looked at combined the echoes about, again, over a 3-year period, we have about more than 10,000 echoes. And we looked at guideline-directed pulmonary artery systolic pressure. And that time, the definition was 25, so we chose 40. And we found that, almost 13% of all echoes had that threshold of pulmonary hypertension. And almost 3% had a PSP of 60, which would be really, really severe. Much larger databases came along later on, like the Australia and New Zealand database, which is over 150,000 echocardiogram over a period of a couple of decades. And there they had a lot more data. So if there you look at the PSP of greater than 40, it was almost 18.9%. But if you look at a lower threshold of PSP of 30, almost 50% of people would meet the criteria of having some elevation in PA pressures. What about right heart catheterization? Echo just estimates PA systolic pressure. Great for screening, but maybe not that precision. So what happens if people undergoing right heart catheterization? Well, we had the access to the VA data. So we looked at the prevalence of elevated pressures in this cohort, again, about 20,000 individual cases. And if you look at the older threshold, which is greater than 25 or equal to 25, almost 60% met that threshold. And if you look at more recent, which is greater than 20 millimeters of mercury, almost 80% of all population, all people who came for a right heart catheterization had pulmonary hypertension. And while that's VA data, we don't have a lot of women in the VA data, unfortunately. So what about using an independent cohort? So we collaborate with people at Vanderbilt University. They have a cath database around 4,000 patients, and very similar numbers, so almost 80% with elevated PA pressures or pulmonary hypertension. So if we summarize the burden of pulmonary hypertension based on these thresholds that I showed you before, and those thresholds were associated with mortality, it's pretty, it's pretty significant, depending on the population size, up to 35% in community-based population. Almost half of the patients undergoing echocardiograms are having measurable TR, with measurable TR having pulmonary hypertension, and about 80% of all right heart catheterization having pulmonary hypertension. And just to put some of these numbers into perspectives, and these are, obviously this is apples and oranges, but there's the prevalence of some other, cardiovascular risk factors that are there in the community. We also found that pulmonary hypertension is associated with multiple comorbidities. So on the left side is veterans with elevated pulmonary artery systolic pressures, and this is higher than 60 millimeters of mercury in our VA data. And you see a lot of cardiopulmonary and metabolic comorbidities like hypertension, hyperlipidemia, diabetes, obviously heart failure is resulting in pulmonary hypertension, and COPD. And looking at our right heart catheterization data in a larger cohort, again, some of the similar signals come out, both in our cohort as well as Vanderbilt cohort. So there's a lot of comorbidities present and associated with pulmonary hypertension. And at a patient level, it's obviously common to have multiple comorbidities. Almost a quarter of the patients in our VA cohort had greater than 4 cardiopulmonary comorbidities. It's still kind of unclear how these are interacting and relate to prevalence and prognosis in PH. We've seen that the classification of PH, lung disease, heart disease, pulmonary arterial hypertension, more and more with the newer studies like PVDomics, we are realizing there's a lot of overlap. And we kind of see that in this large databases too, because patients don't decide to have one kind of pulmonary hypertension. They have a lot of comorbidities and they kind of interact to manifest as pulmonary hypertension. All right, so it's common, but does it affect survival or does it have adverse effects? So looking at community-based cohorts again, this is again patients with, in the Olmsted County cohort. I showed you data about prevalence there before. In this particular analysis, they divided it in quintiles. And in the quintile of PA systolic pressure of 30 to 32, very narrow quintile, only 2 millimeters of mercury, and very borderline pulmonary hypertension, we were already seeing 10% mortality over an 8-year period. And in the higher quintile of 34 to 36, it's almost 23% mortality, with a 46% increase in hazards of death every 10 millimeters of mercury. We looked at the same thing in the African-American population of Jackson Heart Study, kind of similar hazards ratio, much more robust adjustment because we did have more covariates to adjust it for. And over a 6.5-year period with PSP of 40, we have a 25% mortality. So in a community-based cohort, these are people living in community that were randomly selected and then followed over time. Presence of pulmonary hypertension does increase your risk of mortality, and I would say could be a 10-year risk could be greater than 20%, which is considered significant when you're thinking about cardiovascular risk factors and not pulmonary hypertension. What about the referral cohorts? Well, the referral cohorts, obviously, it's a sicker population, so not unsurprisingly, the risk is even higher. If you're looking at 5-year mortality in the borderline area of 30 to 40 millimeters of mercury, it's almost 25 to 40% mortality. And greater than 50% 5-year mortality is greater than 40 millimeters of mercury. That was the echo data. If you look at the mortality in hemodynamic data or right heart cath-based data, very similar. So 5-year mortality of about 31%. In the borderline area, which is 20 to 24, it used to be borderline. It is under pulmonary hypertension now, and then greater than 25, almost 50 mortality. So the prognosis, about 20% 10-year mortality in community-based population, to 50% 5-year mortality in the referral population. We know it increases hazards of mortality independent of comorbidities. I did not show you that analysis, but we have done that, and we can see that it's independent risk factor. It more than doubles the risk of heart failure hospitalization in an adjusted model. That's something we looked at in the Jackson Heart Study. I did not show that data as well, but it provides incremental risk information over other heart failure prediction models. Recently, we did an analysis, and this paper is under review, where we looked at pre-existing PH and COVID. And again, we saw if you had pre-existing PH, you had a 58% increase in hospital mortality with COVID. So there's, no matter in what setting we are looking at, if you have pulmonary hypertension, the prognosis is poorer. All right, so what are some of the treatment targets for pulmonary hypertension? And, as we said, it depends on why you have pulmonary hypertension, right? So group 1 and group 4, which is group 1 is the one that has severe vascular remodeling, either genetics or idiopathic, associated with scleroderma or some other disease like HIV. Group 4 is the one that has clots. So in these two particular groups, you target the pulmonary vasculature first, if you can, to kind of decrease the pressures in the system. And then the other target is right ventricle. Well, why right ventricle? Because high pressure by themselves really are not sufficient to cause poor outcomes. What happens is because of those high pressures, right ventricle is unable to keep up with those high pressures and it fails. And that's the main reason for having poor outcomes in pulmonary hypertension. And we'll see that in the second half of the talk. And then the vast majority of pulmonary hypertension is the one that's related with this cardiopulmonary metabolic comorbidities. And these comorbidities either lead to hypertension in the left side, left atrium, causing back pressure in pulmonary hypertension, hypoxia in certain situations, impairment of vasomotor function, or some mild pulmonary vascular remodeling. And in these particular disease, initially, perhaps it's just a risk marker or a biomarker in most group 2 and group 3. And if we don't know very well if it's modifiable, responsive to therapy, but there may be some cases where that may be true. But as in people with particular substrate or susceptibility, having this pulmonary hypertension may lead to excessive remodeling, and there are terms for that, like out of proportion group 3 pulmonary hypertension, or combined pre and post capillary pulmonary hypertension, left heart disease, where then it becomes really a disease modifier and start affecting the overall outcomes in that population. And perhaps in that particular situation, there may be opportunities to both target the pulmonary vasculature or the right ventricle. So general principles of management of patients with pulmonary hypertension is related to management of volume, oxygenation, metabolic diseases, diabetes, hypertension, treating their valvular disease, increasing physical activity, and then performing detailed workup such as right heart catheterization based on the current guidelines. And then further group workup for certain select patients where we do have targeted treatments for pulmonary vasculature available, and then treating them. But most of the targeted treatment we have right now for pulmonary hypertension target the pulmonary vasculature. But as I mentioned, right ventricle plays a really important role in determining the prognosis of pulmonary hypertension. So what about the RV? So we've known for a while now that right ventricular function is the most important thing that predicts survival in pulmonary hypertension, and not how severe your pulmonary hypertension is. This is just to show, one of the very earlier studies, to show that a marker of right ventricular function, which is called TAPC, which is basically the movement of the free wall of the right ventricle, where the tricuspid valve is, over time. So as you see, there's the QRS. So as the heart contracts, this free wall of the right ventricle, tricuspid annulus moves up, and then it comes down again with the contraction. And the distance between the bottom and the top is called TAPC. And the higher that distance, the higher this part of the heart moves on this axis, the better the function is. And so basically, this is to show that this was a cutoff of 1.8. If you have worse function versus better function, your outcomes are different. And this is true for all. I'm not going to show a lot of data on this because this is well established now. It's true for all different kinds of pulmonary hypertension. And just to highlight this particular study, this was in heart failure population, where they categorized people with normal pulmonary pressures, preserved RVEF, or low RVEF, and high PA pressures. And basically, if you look at the group 3 and 4, which are these two groups, what really matters is not how your pulmonary artery pressures was, but how low your RVEF was. So RVEF is really driving the outcomes even in high PA pressure group. So this is what a right ventricle looks like on a short axis view of an MRI. So what you have is a left ventricle here, and then your right ventricle here. It's a nice thin wall structure, because it's a low pressure system that pushes the same amount of cardiac output to your lungs as your left side to the rest of the body. As the pressures increase that the right ventricle has to work against, similar as you would see if you start lifting a lot of weight, there will be hypertrophy. So the muscle gets thicker and gets adapted to deal with those pressure because you have to manage the wall stress. So you get concentric hypertrophy. You may have slight dilation, but the stroke volume or the cardiac output is preserved from the right side. The systolic function is normal, and the filling pressure is normal. And that's called preserved ventricular arterial coupling, and we'll talk about that briefly next slide. When it becomes maladapted, it gets dilated, and now you have eccentric hypertrophy, your systolic function is reduced, you have fibrosis, your metabolism in the RV is altered, you may have ischemia, altered expression, and you become uncoupled. So what does this uncoupling and coupling mean? And so mechanistically, you can define the failing right ventricle, or in that case, failing left ventricle, by looking at RVPA coupling. So RVPA coupling is the efficiency of energy transfer from the ventricular to the arterial load. And it is defined as EES, which is the end systolic elastance or contractility, and EA, which is the afterload. So it's a ratio of contractility and afterload. And so basically what it means is the ability of the ventricle to keep up with the afterload. So if your ventricle is able to keep up with the afterload, then you're coupled. If it is not, you're uncoupled or you're failing. So how do you change RVPA coupling? Well, RVPA coupling has two components, right? It's the contractility and the afterload. So we're not going to talk about the afterload because there are a lot of therapies, as I said, are already available in the pulmonary vasculature and they're working on, but we have nothing that targets the right ventricle. Everything that we've tried to fix right ventricle with from a medication perspective has failed. So are there any opportunities to increase the contractility? And so if you further break down contractility is basically a ventricle that looks like this and then becomes this, so you can eject blood. And at a cell level or a tissue level, it gets thicker and shorter. So there's some displacement or deformation. And then displacement is usually related to the stiffness of the material or the amount of force you apply. So let's look at stiffness. So stiffness is the extent to which an object resists deformation. So if it's Jello, you don't need a lot of force to move it around, but maybe it's an eraser, you may need a little bit more force to move it around. And so stiffer material needs more force to stretch or squish. And this would impact both the contraction of the ventricle or systole or filling of the chamber or diastole, because you need higher pressures to fill the chamber if it's stiff. And to contract it, you need a lot more force for the same level of contraction if it's stiff. So to study this, we used an animal model of pulmonary hypertension. So we chose two models, one with a milder phenotype and one with a severe phenotype. And the way animals get pulmonary hypertension, and these are rats, if you put them in a hypoxia chamber, the pressures go up. If you give them an injection of SU5416, which is a VEGF blocker, before you put them in hypoxia, the pressure goes up a lot. And so we use these two models, and we use a special strain, which is the CDS strain, which is highly susceptible to pulmonary hypertension. So with these two models, we were able to get some mild pulmonary hypertension. This is right ventricular systolic pressure, which is the same thing as pulmonary artery systolic pressures, was elevated a little bit in SD, but a lot more in the severe model. The end diastolic pressure, which is to show how much filling pressures they have, was again mildly, not much change in the SD rats or hypoxia rat or mild PH, but significantly increase in the severe pulmonary hypertension. And then when we looked at a measure of coupling by echocardiography, we saw that the coupling was not that impaired in the mild pulmonary hypertension group, but significantly impaired in the severe pulmonary hypertension group. And then we did a number of other echocardiography measures to show that the heart cardiac output was decreased in the severe pulmonary hypertension group, The PAT is just another marker of pulmonary artery pressures, confirming that they both had pulmonary hypertension. And then the TAPC, which is the marker of right ventricular systolic function, was also decreased only in the severe group and not in the mild group. So was that because it was associated with the stiffer RV wall? So we actually took the tissue out, right ventricular fee wall, did some biaxial testing. Most of this work was done in very close collaboration with Reza Awaz, who's a bioengineer assistant professor at Texas A&M University, and we have had a long-standing collaboration, and he's a great collaborator. So we looked at biaxial testing, we looked at the stress versus strain, and you can see in the mild, there was no difference between the wild type and the mild pulmonary hypertension group. But in the severe pulmonary hypertension group, there was a significant increase in the stress versus strain, in the stress for each level of strain, which translates into stiffness. So you see a increased stiffness in severe pulmonary hypertension group, not much in the mild. And this was interesting because this was despite having the same amount of hypertrophy. So Fulton index is how much the RV is thick, compared to the LV. And so you had increased right ventricular thickness or right ventricular mass in both the groups, though it was a little bit worse in the CDF group. However, the stiffness was much worse in the CDF group in the SD. And then if you look at the relationship between a coupling parameter that we use echocardiographically derived versus stiffness across these animals, you could clearly see there's a relationship where as the stiffness increases, the coupling dramatically starts dropping. I'm not able to tell you a lot of details about this equation, but this is an equation that can define that Reza uses to define the myocardial properties or stiffness, and has contributions from both the muscle cells and the collagen. And the things that are important conceptually is the myofibers of so collagen and myocytes are the two main components that would decide the stiffness of the ventricle. And it's the amount of each and the intrinsic stiffness of each of these components. And in myofiber, also how they're arranged is important. So first, looking at how the myofibers are arranged, we did not find any changes in myofiber stiffness when we did the calculations. So I'm not going to talk about that. But the arrangement of the myofibers we did. So we took several serial sections from the RV free wall, and we looked at how the orientation of the myofibers changed from endocardium, which is inside the heart, to epicardium, which is outside the heart. So these myofibers normally are not all aligned the same from endocardium to epicardium, and they're aligned at an angle, and the angle is more positive inside the heart. And as you come outside the heart or the epicardium, the alignment changes to more negative. So it goes from up to down. And this is just plotted in these mild pulmonary hypertension animals versus severe pulmonary hypertension animals. And there was a difference. It did not look the same. The alignment did change between the mild and the severe pulmonary hypertension. And there are many markers of alignment you can use. One of the ones we used here is helical range, which is how much it changed. So if there's a big drop, say from positive 90 to minus 90, you have a big range. And if it's just like 45 to 45, there's obviously a smaller range. So the more the helical range was, the better the coupling was. And the small the helical range was, the lesser the coupling was. So here again, we can see the myofiber orientation did relate to coupling. We also looked at collagen, and we looked at collagen content. The collagen content, the fibrosis, in another word, was significantly increased in both mild and severe. And significantly, there was a trend that it was much worse in the severe, but not too much worse. However, the stiffness of the collagen fibers was no difference between these groups. And another marker we looked at was the collagen fiber tautness, which is, if you look at the length over distance, so how taut each fiber was, and we could do some of those measurements using the histology, the tautness was much more increased in CDF compared to SD. Looking at did they relate with stiffness? So both collagen content and collagen fiber tautness related with stiffness. So higher the collagen, And higher the tautness, worse the stiffness. But could one of these things, like collagen content and fibrosis, can be used as a therapeutic target to reduce stiffness and improve function? So a lot of things cause fibrosis, ischemia, altered metabolism, cardiomyocytes, macrophages have a role to do that with a lot of mediators, including neurohormones, which has been the primary target in the left ventricle with ACE inhibitor therapy and beta blocker therapy, inflammatory mediators and growth factors, which have changed fibroblasts to myofibroblasts, leading to collagen deposition. So looking at neurohormonal, initial studies have looked at carvedilol, which is a beta blocker, again, using animal models. If you give beta blockers, then you don't see any changes in the pressures, but there is decrease in fibrosis and increase in right heart function. Unfortunately, this therapy has not translated into patient population, and there are still some studies trying to do that, but we haven't seen a robust change. As we saw with the left ventricle, we have amazing improvement in patients who get on beta blocker with lower LVEF. The other important neurohormonal signaling is related to angiotensin signaling. Again, that was tried for the right ventricle. It did not work. This is an animal study we did where we looked at the PH animals obviously had more collagen, higher pressures, and poor right ventricular systolic function. And then we gave them Valsartan, which is an angiotensin receptor antagonist. It's a great treatment for left ventricular failure. It really did not make any difference. However, there was a new medication where Valsartan plus neprilysin inhibition. So it's sacubitril valsartan. It's a new medication that's used for LV, not really tried in the right ventricle yet. And we did see a significant improvement with the decrease in collagen, decrease in RVSP, and increase in right ventricular systolic function if we try this therapy. So that's another promising therapy that can be used for the future. I'm going to briefly talk about a novel target of RV fibrosis that we've been looking at, which is the nicotinic AChR pathway. And we learned about this and repeatedly, collaborating with Sharon on a study. We're looking at effect of cigarette smoke on lung function and lungs. We started measuring the right ventricular pressures and noted that their RVSPs were not different, but they did have poor right ventricular function, as you see with TAPSE, and also increased fibrosis in the RV, but not in the LV, in these animals exposed to cigarette smoke. And then looking at isolated fibroblasts from these animals, we realized that exposure to cigarette smoke actually caused increased fibrosis, increased fibroblast proliferation, which could be inhibited by inhibiting the nicotinic receptor or alpha-7 nicotinic receptor, which can be found in non-neuronal tissues, and this is just what the receptor looks like. And when we get rid of this receptor by using siRNA and then expose them to nicotine, the cell proliferation and fibrosis does not happen. So we said, well, it happens in cigarette smoke. Is it happening in pulmonary hypertension? And so we used our animal model, which I'd shown before, where we have the increased RV systolic pressure with Sugen hypoxia associated with decreased cardiac output, decreased right ventricular systolic and diastolic function. The animals do have increased collagen as expected, but they also have increased levels of acetylcholine. So acetylcholine is the natural ligand for the nicotinic acetylcholine receptor. And so we saw that in these pulmonary hypertension animals, there's an increase in acetylcholine levels. And this was associated with a decrease in acetylcholine esterase content in the right ventricle. So we think the acetylcholine levels were increased because of decreased degradation of the acetylcholine. And in the same time, we also saw an increased expression of the cognate receptor, which is the alpha-7 nicotinic acetylcholine receptor in these cells. None of these changes happen in the LV. We got some tissue from patients with pulmonary arterial hypertension. Again, we saw fibrosis in that samples and associated with the increase in alpha-7 receptor expression. And so we kind of summarize what we found there was that we saw increased hypertrophy, increased fibrosis, decreased systolic and diastolic function, which is associated with the increased acetylcholine and increased acetylcholine receptors. And we did a number of cell culture work to find out the mechanism of how this is happening in cardiac fibroblasts. After stimulating these receptors, we saw an increase in calcium, increase in phosphorylation of EGFR receptor. All of this was related in cell proliferation and collagen production. Well, can we use this therapeutically? So we treated these animals with pulmonary hypertension with mecalamine, which is blocks nicotinic receptors. And we saw that when we used that, we saw some improvement in their right ventricular systolic and diastolic pressure. Saw improvement in their right ventricular hypertrophy, collagen, as well as parameters of systolic and diastolic function. But these were animals with pulmonary hypertension, so obviously it was also affecting the pulmonary vasculature and not only the right ventricle. So what we ended up doing is taking nicotinic acetylcholine knockout mice, and we put PA bands on them. So when you band them, there is no chemical. They don't get any vascular disease. It's just the right ventricle sees a lot of high pressures and has to respond to it. And this is just to show that they did have high pressures across the band, had increased right ventricular systolic pressure, hypertrophy, increase in collagen, only in the wild type mouse. If they did not have nicotinic receptor, they did not get right ventricular fibrosis. So despite having similar amount of hypertrophy, they did not develop fibrosis. And if you, the same thing about right ventricular systolic function and diastolic function, it was only worse in the wild type mice. Lack of nicotinic receptor protected these animals from pulmonary hypertension, from right ventricular dysfunction, despite having the same levels of acetylcholine in the RV. So both increased their acetylcholine levels, but the collagen deposition and systolic and diastolic function did not change. So to summarize, stiff RVs associated with right ventricular dysfunction is independent of hypertrophy. Stiffness correlates to myofiber orientation, collagen content, and tautness. And so there may be some new targets for improving right ventricular function and stiffness by attenuating fibrosis. I'm going to just 2 or 3 slides more. I'm going to give you a brief preview of what we are currently working on, which is looking at the second side of the equation, because displacement is also associated with force. So you need more force for displacement. So is there a way we can increase the force in the RV? And the main fuel for the force in the RV, or in the heart, is ATP. And the main way the ATP is generated in the heart is through fatty acid beta oxidation. Almost 95% of the ATP in the heart is derived from mitochondrial oxidative phosphorylation in the heart. And as you can see, this cartoon is both required for contraction of the actin-myosin filaments, as well as relaxation, because it helps sequester calcium back to sarcoplasmic reticulum. So oxidative phosphorylation is actually impaired in the dysfunctional RV. So there's many ways the heart can use fuel, which makes acetyl-CoA, some little biochemistry for us. It goes through a TCA cycle, and then goes to electron transport chain complexes in the mitochondria to produce ATP. And this is a model for the PA banding in rats. So again, high pressures, poor RV function without anything happening in the lungs. You see decreased right ventricular systolic function and cardiac output. When we measured the activity of electron chain complexes using Ouroboros, we saw a decreased activity of complex 1 and complex 2 that would lead to decreased ATP production. No matter what fuel we use, whether we use palmitate, which is fatty acid oxidation, or pyruvate, which is glucose oxidation. So there was an impairment of the electron transport chain in the mitochondria of these hearts that was associated with poor oxidative phosphorylation. These mitochondria are interesting organelles, right? So they have all these cristae, which are by lipids, and one of the interesting lipids in these cristae is cardiolipin. And these cristae is where all these complexes live, which cause oxidative phosphorylation. And they're not just alone, they're organized themselves into what we call supercomplexes as well. So cardiolipin in the mitochondria plays a critical role in mitochondrial function and energetics. It's about 10 to 20% of mitochondrial lipid, and it helps with the membrane integrity, helps with the cristae morphology and curvature, stabilization of these respiratory complexes where oxidative phosphorylation happens, and also maintain protein and membrane interactions. And cardiolipin is synthesized in the cell, in the mitochondria, by a pathway which ends with maturation of cardiolipin using these 2 enzymes, which is one is an alpha subunit of transfectional protein, or we'll call HADHA, and the monolysocardiolipin acetyltransferase. So the mature cardiolipin is the one that maintains the mitochondrial structure, maintains the complexes there so they can function healthily in the mitochondria in the heart. When we looked at the mitochondria of the pulmonary hypertension animals, the PAB animals, they looked really different, right? So this is a normal mitochondria. You can see all these lines that are narrow. These are cristae. And this is the banded animals mitochondria, where the cristae are wider. You have a loss of cristae in some mitochondria. So definitely looks abnormal. When we looked at the cardiolipin levels in these mitochondria, they had much less mature cardiolipin than the mitochondria of normal animals, also associated with the enzyme that was important for maturation of this cardiolipin, which is HADHA. So this is a project that's work in progress. We just got funding for it. Is that can restoring the mature cardiolipin improve right ventricular mitochondrial structure, oxphos, and right ventricular pH. So now we're trying to see if there are these energetic deficits that are present in a dysfunctional RV. Can they be improved? And this is one approach to improving them. We're looking at a couple of other approaches. And could that then restore function of the RV despite having high PA pressures? And that could be another therapeutic target. So to summarize, I think I showed you data that pulmonary hypertension is common, is associated with multiple comorbidities, and independently associated with poor outcomes. And then there are opportunities for right ventricular targeted therapies to decrease stiffness and improve energetics. And once we get them, I think that can make a significant dent in improving the outcome of this patient population. This work obviously not done in the vacuum, and I've been really, really fortunate to work with a lot of collaborators, trainees on different projects related to pulmonary hypertension, whether it's the population science program, the clinical program, and I shared some of the data for the population science, or the basic research program. And thank, without all these people, we wouldn't be able to achieve anything. Just a quick plug-in for a conference that's coming. If you think that you like what you saw about right ventricle, we are having a wonderful symposium in October, the reception on Friday evening, and then 19th and 20th we have sessions. CME is available for it. We have speakers coming from all over the country who are experts in their field in the right ventricle. Please, you can use this QR code, check out the agenda. It's a very, very reasonably priced event. We also have opportunities for people to present their work and abstracts as well as oral presentations. So it's a combined effort from Cardiovascular Institute, COBRA, CVRC, and the Center for Advanced Lung Diseases. And Dr. Vengitulo and I are co-hosting this. All right. Thank you, Sharon.
Well, that's fantastic. Thank you so much. Really, bravo. The thing that I love, Gaurav, about the work that you have done, you've presented, is that it really spans the translational spectrum from mitochondrial energetics to population. To assessments of populations and epidemiology. So it's really quite remarkable. I would like, folks should feel free to put enter questions into the chat. I'll start with a couple of questions. One is that in pulmonary fibrosis, fibrosis affecting the lungs, tyrosine kinase inhibitors have recently, not that recently, a few years ago, found to really change the course of that disease. They're not removing existing fibrosis, but slowing the development of fibrosis. And presumably by interfering with various growth factor receptors. And I just wondered, has anyone thought about looking at tyrosine kinase inhibitors and right ventricular fibrosis related to pulmonary hypertension?
So not for the RV, Sharon, but LV, people have tried pirfenidone to see, and I think there's a small study there like in HFpEF population or something that I'm not exact, I don't remember the exact study because I know Tasneem Imran, is a mentee. She's working on HFpEF and she's looking at some of those profibrotic plaques in the left ventricle. So there have been some that have tried it, but I'm not aware of any larger scale study in patients. What may be interesting to look at is we have a cohort of patients who are on that. Unfortunately, as you know, what happens is people don't look at the RV,
Yeah.
in all these studies. So, if we have the data to look at some of the RV parameters, and in human studies, looking at RV fibrosis is actually extremely challenging. We did a study looking using cardiac MRI and extracellular volume imaging in patients with pulmonary hypertension. And it was easy to see and quantify fibrosis in patients with pulmonary hypertension, but in normal, if they're not hypertrophied, it's very, very difficult because RV is such a thin wall structure. So we don't have great ways of non-invasively assessing right ventricular fibrosis in normal patients. And so, but that is certainly some people have tried it in the left ventricle because you can assess it easily in the left ventricle. But it remains an open question, and I think there are preclinical studies have been done on that area as well.
Oh, interesting. And then I was frankly surprised today looking at the relatively high prevalence of elevated pulmonary arterial pressures in the population studies. And I wondered, is there any gender difference in this?
Yeah, so we looked at that in the Jackson Heart population because that's the population that we worked with, Sharon, and to see if sex was an independent variable, and it was, and we saw women had more, and that's why the prevalence. One of the contributors of higher prevalence in Jackson Heart studies was also there were more women in that. We
Yeah.
also had a lot more hypertension, obesity, diabetes, and other comorbidities in it. And that's why I'm not 100% sure that that was all driven by race. It may be other social determinants of health and other issues and other comorbidities that may be driving the high prevalence in that particular group.
And then what about in your animal studies? Any sex differences there in the RV stiffness?
We have not observed any right now. So it's interesting is that certain sexes of animals don't get that high pulmonary hypertension. Like for the CDF animals, this is really severe phenotype. They're generally all reported with male animals and not female. And I think it's a susceptibility issue or something that they've never had a great response with female CDF animal. Sujan, the other strains, yes, we've used both males and females, and we haven't really seen a clear difference yet. But we will. The thing is to tease out the difference. Sometimes we need a lot more
Right.
numbers, and I think now we have a larger cohort that we did as part of the team science project. So we have more than 100, 150 numbers now with both sexes, and we will be able to tease out even small differences in that larger cohort.
And so Peter Quisenberry has a comment in the chat. Thank you for the great talk. We are interested in the role of clonal hematopoiesis of indeterminate potential, CHIP, in pulmonary hypertension. Could you please comment on potential mechanisms that may be linking these pathologies?
Peter, I'm not an expert in CHIP, so I know there's a lot of interest nowadays in this, even in cardiovascular disease areas. I mean, I think one potential mechanism it would be it's Pat. Sorry, I think you're logged in as Peter Pat. Sorry. So the key question would be that is inflammation something that could be a common underpinning for both these pathophysiological mechanisms, and I think that may be something I would think that could be interesting to look at. There's obviously a huge area of how inflammation affects both the right ventricular function as well as the pulmonary vascular disease that I did not go into today. But we are exploring some of the inflammatory pathways as well. So if there could be a common pathway there, with inflammatory cell phenotypes and how they respond with this particular aspect. That may be something.
Great. Okay, well, it's 1 o'clock now, and our time is up, but I just want to thank you once again, Gaurav, for being the first speaker of the year, actually volunteering to do this in September, much to my great delight. And we really appreciate it. It's really great work, and thanks to everyone who's joined us today.
No,
See you
thank you
later,
very much.
everybody.
Bye-bye.